Hello, everyone. This is Shadrach from CVI 2025. I'm really privileged to be with Dr. R. Clement Darling, vascular surgeon attending CVI, and has built a big system in vascular collaboration with cardiology. And when we talk about how to build system in collaboration between vascular surgery as well as cardiology. Thanks for being with us.
Thank you very much. It's a pleasure being here. I grew up in Boston and trained in Boston, where it was very segmented, the cardiac surgeon, cardiology, and vascular surgery. When I went to Albany, New York, we actually created a system where we worked very closely with cardiac surgery, cardiologists, the private and the university, to create a kind of a vascular network that covers from Canada down to Westchester, New York. So it's a large area and goes east and west also. The idea was that we would have small satellite offices within 70 miles to 100 miles of our main office, see patients there, and then see them in follow-up. Complicated patients would come to us. Also, since much of the aortic dissection work, type A is obviously done by cardiac surgery. We do the type B. These patients would be traveling a couple hundred miles to see the cardiac surgeon, the cardiologist first, and then come back and see us. So we have a complex aortic center where we can see the patient with the cardiac surgeon and the vascular surgeon simultaneously, which saves on their travel expenses and also gives them a long-term plan of exactly how to be treated. And this can go for pretty much every vascular disease. And I think one of the ways we built up our system is by having easy access. We had a 1-800 number, a 1-800 vascular number that they can call. All the ERs within 200 miles have it, and
Wow.
they can call whenever they have any issues with vascular problems. One of the concerns is that only 3,600 board certified vascular surgeons in the country, and when you live in a rural area, it's very difficult to get reasonable vascular care in a certain amount of time. So we've tried to create a system that allows patients to get this care as quickly as possible, and they can see experts when they need to.
Yeah, and this is why your collaboration was with cardiology also to see if they can take over these cases or to help you kind of co-manage the cardiac or structural cases.
A little bit of both, especially co-managed in
Yeah.
most of the cases. All of our patients, as you know, have systemic vascular disease or cardiac disease, and so we feel the best way is to treat the patient in a holistic manner, so that we work with a cardiologist. Ironically, when we started doing endovascular work, which is 80% of what we do, and cardiologists doing the same, both our practices volume went down when we tried to separate and contain the patients ourselves.
Interesting.
When we worked together, actually our volume went up, and it just made it
Why is
a
that?
lot easier. I think because we worked together, patients understood that they could get the best and most comprehensive care if we had put our minds together. In Albany, we've always had a meeting at 7:15 amongst all the surgeons, where we get about 10 or 15 transfers per night, and we decide what the best options for the patients. We include, talking to some of the cardiologists because they see all our patients. And now that we're doing much more aortic arch work, we work closely with the cardiac surgeons also. So it's created a system that is very communal and friendly as opposed to competitive.
Competitive,
Yeah,
yeah.
and there really has been no turf battles, and it extends to interventional radiology. We have a room in interventional radiology every day where we do, so we don't have to go to a cath lab or go to the operating room. We go to a suite that's really meant for peripheral interventions, as well as having an outpatient angio suite within our office.
Yeah.
So we can give comprehensive care. Patients like the fact that we can give them a good plan at once, and they can leave knowing exactly what to expect in the future.
There is a lot of people graduating now. They don't want to do a satellite. They say they want to be at the main campus and they want to do a satellite. So what's your advice for these people?
But that's another we've gone through many iterations because we've been doing this for 25 years. And we found that if we sent people out to the smaller hospitals, their education was not as vigorous as it would be as if they went back and forth. So we have people in the peripheral hospitals that come to the main center once or twice a week, and they take their complicated cases to the main center so they can actually have backup from some of the more senior members, and also feel part of the system as opposed to feeling isolated and sending all their complicated cases to somebody else. We've been considered a socialist group because we don't it's not an eat what you kill model. So the model is that if the group benefits, everybody else benefits.
Yeah.
And I think that we uniquely had worked for the hospital I worked at the hospital for 14 years. We were private for 14 years, and now we're back in the hospital for the last 6 years. So we've been through all iterations, and each time during that, we've actually stayed friendly with the hospital as well as the private practice people, and we've also had the paradigm that everybody benefits. And there's an old Japanese proverb that none of us are as smart as all of us, and so we try to work together as a group.
Absolutely. And so for when you say this big catchment area, like you say, rare, and do you have any difficulty hiring for areas like this, or usually you have enough? Yeah.
Well, that's why I think we have to include them in the main center. It's especially when you live in a rural area. Unless people want to go hiking and skiing and whatever, it's hard to hire in an upstate. And everybody wants to go to the big city, or thinks they want to go to the big city.
Yeah.
But there are benefits for being in the smaller hospital, because nowadays, we have certain people that like to do venous work. We have people that like to do peripheral interventions. What I'm usually saddled with is a lot of the complex aortic work. As well as actually help a lot of the other specialties. I do a lot of surgical oncology. I do a lot of assisting with TAVRs. We do carotid-based TAVRs. We've done about 250 of those. We do about 2 a week. And again, even though it might not be economically the best thing to do, but it's best for the patient.
Absolutely.
And we did two yesterday, and it went very expeditiously, and the cardiologist is very happy. And
now you mentioned
everybody worked, and we get to go home by 4 or 5. So the goal is to make people's lifestyles good, make people their patients get well taken care of, and make them happy to be at work instead of feel that they have to either do something to make more money or they have to compete with their internal. We always say you want to compete outside, not inside.
No.
So.
And especially you mentioned something about carotid. You got me intrigued. So you said 2 a week. You do 2 to 3 a week of carotid.
Yeah, 2 a week.
So which one? What's your protocol for choosing carotid?
Well, the interesting thing, the iteration of that went through is that there were some patients who had poor arterial access, and those are the ones we first started with. But then we realized that cardiology was having a significant amount of complications in morbidly obese patients. So anybody over a BMI of 32 gets a carotid-based TAVR now. Well, I did a 45 one yesterday. We can make a tiny little incision in the neck and access it. It takes less than 40 minutes for the whole procedure with open and closing. So the hospital somewhat mandated that anybody that's so morbidly obese gets a carotid-based TAVR. If you look at the data, when we were doing axillary-based, or when they were doing axillary-based, they had a 13% stroke rate. We've had 2 TIAs out of 250, and one person had to go back for bleeding, and those are the only complications we've seen so far.
Amazing. And it's a great alternative access and usually safer than going into
it's funny, in 2006, we actually had to do a ruptured thoracic aneurysm the only access we had was carotid. So we become comfortable with doing that, although it's not our preferred method for EVARs or TVARs, but we felt comfortable doing that. And I think that helped us move this along very quickly. And the cardiologists have really bought into it and are very happy with it.
That's great. Well, again, thank you again for Dr. Darling for being with us. And watch his videos and others on the YouTube channel. This is Shad Race coming to you from CVI 2025.